Welcome to the deep dive. We're really glad you could join us today. We've got these MSRA revision notes in front of us, quite dense, and our mission really is to break them down, get to the essentials, make it stick for your revision. Today, we're diving into IgA nephropathy. You might know it as Berger's disease. We're going to go through these notes step by step and pull out the absolute key facts.
Yeah, and IgA nephropathy is it's a really significant condition for anyone learning medicine. It's surprisingly common, actually. So this deep dive should really help clarify the core ideas and those high-yield facts you need.
Okay, let's start right at the beginning then. What is IgA nephropathy, fundamentally?
Well, the notes define it pretty clearly. It's a kidney disorder, and it's characterized by IgA antibodies building up, depositing in the glomeruli.
Glomeruli, the kidney's filters.
Exactly, those tiny loops where the blood gets cleaned. And when this specific type of antibody, IgA, gets stuck there, it kicks off inflammation. And that inflammation, well, that's what damages the kidneys over time.
And it matters because, as the notes say, it's the most common primary glomerulonephritis globally.
That's the one, yeah, the most common worldwide. That fact alone tells you why it's essential to understand.
And the notes mention a classic presentation. Something about blood in the urine after a cold, is that right?
That's a really key scenario to remember. Often presents, particularly in younger people, with visible hematuria blood in the urine maybe a day or two after an upper respiratory infection. Sometimes a stomach bug, too.
Okay, so that link, that timing, is a hook.
Definitely. And it's a chronic condition, an autoimmune type kidney disorder. It's part of that glomerulonephritis group. But it's not always mild. The notes highlight a pretty stark statistic. About 25%, so 1 in 4, can progress to end-stage renal disease, ESRD.
Oh, okay. So needing dialysis or a transplant eventually.
Potentially, yes.
Right, so let's dig into the how. How does this actually happen? What's the mechanism the notes describe?
So the core issue, according to these notes, involves a specific type of IgA called IgA1. It's often elevated, but the real problem is that it has abnormal glycosylation.
Glycosylation, sugar molecules attached to it.
Exactly. And they're not attached correctly. Specifically, it's deficient in galactose. So think of it as a slightly faulty antibody. And this abnormal IgA1, well, the body seems to see it as wrong. It starts making antibodies against this faulty IgA. These then bind together, forming immune complexes, little clumps of faulty IgA and the antibodies attacking it. These complexes circulate in the blood and eventually get trapped in the kidney filters, specifically in the mesangium.
The mesangium. That's like the support structure within the glomerulus.
Precisely. And when these complexes build up there, they activate the mesangial cells, triggering inflammation, scarring, basically kidney injury. So that whole sequence: abnormal IgA, immune complex formation, mesangial deposition, inflammation. That's the heart of the pathogenesis.
And the notes mention genetics playing a role.
Yeah, it seems like genetic factors can influence how likely someone is to make this faulty IgA or how their immune system reacts to it. It's not purely genetic, but there's a susceptibility.
Okay. And what about when pathologists look at a biopsy? The notes mention the Oxford classification.
Right, the Oxford classification. It's a system pathologists use to grade the damage they see under the microscope. They look for 4 key things. MESA criteria, basically. M is mesangial hypercellularity, how crowded the mesangium is. E is endocapillary hypercellularity, inflammation inside the tiny capillaries. S is segmental glomerulosclerosis, scarring in parts of the filter. And T is tubular atrophy, interstitial fibrosis, damage to the surrounding kidney tissue. And the crucial thing is these features are independent predictors of how likely the disease is to progress. It helps guide prognosis.
Got it. So MS helps predict the outcome. Okay, shifting gears slightly. Who gets this? What are the causes and risk factors mentioned? Is the cause clear?
Well, the notes say the exact cause isn't fully understood. It's seen as multifactorial. You've got the genetic predisposition, that abnormal immune response with the IgA glycosylation issue, and likely environmental triggers.
Like infections.
Infections are definitely key triggers, especially respiratory or GI ones, as we mentioned. That fits the classic presentation.
And specific risk factors listed. Things to look out for.
Family history is one suggests that genetic link, frequent respiratory or GI infections again, and certain specific genetic variations are implicated, though maybe less crucial for general revision right now.
But there's a demographic point that stood out.
Oh, yes, absolutely. Males are more commonly affected than females. The notes are quite clear on that. That male predominance is a key recall point, maybe a 2.1 ratio in some populations.
Okay. And associated conditions, does it often come with other diseases?
It can do. The notes list a few important ones. Alcoholic cirrhosis is mentioned. coeliac disease and its skin form, dermatitis herpetiformis. And a big one is Henoch-Schönlein purpura, HSP. The notes actually say the pathophysiology often overlaps between IgAN and HSP, which makes sense. HSP is like a systemic IgA vasculitis, often hitting the kidneys too.
Right, so HSP and IgAN are closely related. That's useful. So if someone presents with symptoms suggesting IgAN, what else should be on the differential diagnosis list according to the notes?
Good question. You need to rule out other things that cause glomerular damage. So other types of glomerulonephritis, lupus nephritis, for example, especially if there are other signs of SLE. Post-infectious glomerulonephritis is a key differential, but the timing is usually different weeks after infection, not days like IgAN. Membranoproliferative glomerulonephritis is another possibility. It's about figuring out why the glomeruli are inflamed.
And just to quickly recap those associated diseases again from the notes, HSP, SLE, hepatitis, dermatitis or herpetiformis, ankylosing spondylitis, cirrhosis, coeliac disease, even HIV infection, and that rare familial form.
Quite a list. Shows it can link into various systemic issues.
Let's talk numbers then. Epidemiology. How common is it really, and where?
Well, as we said, it's number one. The most common primary glomerulonephritis worldwide. The global incidence is roughly 2.5 per 100,000 per year. But, and this is interesting, there's huge geographic variation. It's much more common in East and Pacific Asian countries.
It's less common elsewhere.
Much rarer in African countries, for instance. The reasons aren't totally clear, likely genetic and environmental factors.
And the male-to-female ratio you mentioned?
In European and American populations, the notes state about 2.1 males to females. Reinforces that risk factor.
And the typical age?
Peak diagnosis is usually in the second and third decades, so people in their 20s and 30s, younger adults.
So that picture, young male, maybe recent infection, potentially Asian background, that really helps narrow it down clinically, doesn't it?
It's a very strong pattern to keep in mind, yes.
Okay, so what symptoms would someone actually experience? What are the clinical features described?
It's quite variable. The notes stress that. Some people are totally asymptomatic, discovered by chance on a urine test maybe. Others have quite obvious signs. But the classic picture, the one that comes up again and again, is that young male with recurrent episodes of visible blood in the urine macroscopic hematuria, often popping up after a respiratory infection.
Right, that seems to be the core presentation.
It is. Other common findings can include protein in the urine, proteinuria, high blood pressure, hypertension, and sometimes swelling edema. Though the notes do say significant proteinuria, edema, and hypertension are less common initially, often it might just be that hematuria after infections for a while. If their serum creatinine starts to rise, that's a sign that chronic kidney disease, CKD, is setting in.
And the disease course, is it always progressive?
Variable again. The notes say many cases are relatively benign, stable for long periods, but it can progress, sometimes rapidly, which is called rapidly progressive glomerulonephritis, but that's rarer. More often, it's a slow progression towards ESRD in cases that don't remit. An interesting point from the notes. Visible hematuria seems more common in younger patients, while older patients might just have microscopic hematuria found on testing.
Okay, so a real spectrum. Given this variability, how do you nail the diagnosis? What's the definitive test?
The notes are absolutely clear on this. The definitive diagnosis requires a kidney biopsy. Full stop.
Right. No biopsy, no certain diagnosis.
Exactly. You can suspect it strongly based on the clinical picture and other tests, but confirmation needs that tissue sample.
So leading up to that, or alongside it, what investigations are typically done? What's the workup?
Okay, so the notes list a few key areas. First, urine tests. You'd start with a urinalysis, a dipstick test, looking for blood and protein. Then, urine microscopy is crucial. Looking under the microscope for red blood cells, white blood cells, and especially red blood cell casts. Those suggest the bleeding is coming from the glomeruli. Quantifying the protein is vital for prognosis and management. So a 24-hour urine protein measurement, or often now a spot urine protein.creatinine ratio, UPCR.
Okay, urine covered. What about blood tests?
Key one is serum creatinine to assess kidney function, usually reported as an estimated GFR or eGFR. You'd also check cholesterol, as kidney disease increases cardiovascular risk. Plasma IgA levels can be checked. They might be elevated in maybe 30–50% of patients, but importantly, a normal IgA level absolutely does not rule out IgA nephropathy. So it's not a great diagnostic test on its own.
Not reliable enough, then.
Really. There's mention of serum under galactosylated IgA, that faulty IgA we talked about, but the notes say that's still largely investigational. And of course, blood pressure measurement is vital.
And then, the big one, the kidney biopsy.
Yes, the gold standard. The notes mention the techniques used. light microscopy to see the overall structure, electron microscopy for fine detail, and crucially, immunofluorescence. Immunofluorescence uses specific stains to light up proteins, and the hallmark of IgA nephropathy is seeing deposits of IgA and often C3 complement protein lighting up predominantly in the mesangium. That confirms it.
And gives you those Oxford MEST scores for prognosis?
Exactly. Diagnosis and prognosis from the one sample. Oh, and one specific point the notes make. In patients over 50, they suggest doing protein electrophoresis to rule out myeloma, which can also cause kidney issues.
Good point for the older age group.
Yeah.
Okay, so diagnosis confirmed by biopsy showing IgA. How do you manage it? What's the treatment strategy according to the notes?
The main goals are pretty clear. Slow down the kidney damage progression and manage the symptoms. The absolute priorities are controlling blood pressure and reducing proteinuria. Those are key.
How do you do that? What are the approaches?
The notes outline a kind of tiered approach based on how severe it looks at diagnosis. If someone just has blood in the urine, minimal or no protein loss, and normal kidney function, GFR, the approach is often just monitoring. Regular checkups, but no specific treatment needed initially.
Okay, watchful waiting if it's mild.
Pretty much. But if there's persistent proteinuria, say over 0.5 or 1 gram per day, even if kidney function is still okay or only mildly reduced, then the cornerstone of treatment is an ACE inhibitor or an ARB.
Like ramipril or losartan.
Exactly. Those are vital. They lower blood pressure, yes, but they also directly reduce protein leakage from the glomeruli, which is shown to slow down the progression of the kidney disease itself. Super important.
Right. And if that's not enough or the disease is more aggressive,
then immunosuppression might be considered. The main option mentioned is corticosteroids, like prednisolone, usually for several months. This is typically reserved for patients with more active inflammation on biopsy, or who haven't responded well enough to ACE/ARBs and still have significant proteinuria. The notes caution, though, that stronger immunosuppressants are generally kept for very rapidly progressive cases, and you'd avoid them if the biopsy shows lots of chronic scarring, already less likely to help then.
makes sense. What about non-drug measures? Lifestyle stuff.
Yes, definitely important. The notes list regular exercise, maintaining a healthy weight, and importantly, a low-salt diet. All help with blood pressure control.
And long-term, if it does progress.
Well, if it progresses to ESRD, then the options are dialysis or a kidney transplant. But, and this is a key point from the notes, IgA nephropathy can actually come back in the transplanted kidney. It recurs in a significant number of cases.
That recurrence after transplant.
It is a real challenge. Oh, and one other specific management point, tonsillectomy. The notes mention there's some evidence it might slow progression, perhaps by reducing infectious triggers for IgA production. But it's generally not recommended specifically to treat IgAN unless the person is getting recurrent tonsillitis anyway.
Interesting detail. Okay, so that's management. What about the overall outlook? Prognosis?
Again, the notes emphasize variability. It really depends on those key factors. How much proteinuria, how well blood pressure is controlled, the biopsy findings, those Oxford scores. Outcomes can range from totally stable function for decades to progression to CKD or ESRD.
Are there specific markers for good or poor prognosis listed?
Yes, and these are really high yield for revision. For a good prognosis, interestingly, the notes list having episodes of frank visible hematuria. Might seem odd, but perhaps it indicates a more intermittent process.
Okay, visible blood might be better than constant microscopic findings, perhaps, and poor prognosis markers.
These are the ones to really focus on. Poor prognosis is associated with being male, significant proteinuria. The notes often use cutoffs like 1G day or 2Gu day, hypertension, especially poorly controlled, smoking, high cholesterol, hyperlipidemia, and even a specific genetic marker, the ACE gene DD genotype. Those are red flags.
Got it. Male sex, high protein, high BP, smoking, lipids, ACEDD.
Exactly. Quantifying the risk, the notes reiterate that maybe 25% develop ESRF. Another figure mentioned is 40% reaching CKD or ESRD within 20 years. Predictors, again, are high proteinuria, hypertension, reduced eGFR at presentation, and those bad biopsy features like scarring.
And slightly higher mortality overall before dialysis transplant.
Yes, the notes mention that too. Likely linked to the kidney disease itself and associated cardiovascular risks.
So definitely conditioned with potentially serious long-term consequences. What are the main complications that can arise?
The biggest ones stemming from IgAN itself are progression to chronic kidney disease and ultimately end-stage renal disease. High blood pressure is both a feature and a complication, increasing cardiovascular risk significantly. And while maybe less common initially, severe protein loss can lead to nephrotic syndrome characterized by heavy proteinuria, low albumin, edema, and high cholesterol. But the notes really stress that prompt diagnosis and effective management, especially hitting those BP and proteinuria targets, are key to minimizing these complications.
Right. Okay. That's a really thorough walkthrough. Just to hammer home those key points for revision, let's do a quick recap.
Sounds good.
Classic presentation to picture.
Young male, visible blood in urine, maybe a day or two after a throat or gut infection.
Definitive diagnostic test.
Kidney biopsy, always. Shows the IgA deposits on immunofluorescence.
Main management goals.
Control blood pressure, reduce proteinuria.
And the first-line drugs for that.
ACE inhibitors or ARBs. Absolutely crucial.
And the big red flags for poor prognosis.
High proteinuria, high blood pressure, male sex, reduced kidney function, EGFR, significant scarring on biopsy.
And the core mechanism tying it all together.
That abnormally glycosylated IgA1 forming immune complexes that deposit in the mesangium, triggering inflammation and damage.
Perfect. It really does all link back to that.
Yeah.
Thinking about all this from the notes, it's fascinating, isn't it? How this one specific antibody issue can lead to such a massive range of outcomes, from almost nothing to needing a transplant. And even then, the fact it can come back in the new kidney.
It really underscores the complexity, doesn't it? The interplay between the immune system and organs. Still lots to figure out.
Absolutely.
Yeah.
Well, that brings us to the end of this deep dive into IgA nephropathy using these MSRA revision notes. We really hope breaking it down this way has helped solidify those key points for you.
Yeah, hopefully it's made things clearer. Understanding these pathways and presentations is so important, whether for exams or clinical practice.
And if you are revising, especially for the MSRA, and you want more practice questions and detailed revision materials structured just like these notes, you can find them over at passthemsro.com.
They've got a great range of resources there.
And if you're looking for some free materials to get started, check out freemsra.com as well.
Always good to have free resources, too.
Definitely. Thanks so much for joining us on this deep dive. We'll catch you on the next one.